Ryan Stanton here with ACEP Frontline, joined today, Leadership and Advocacy Conference 2018. Two folks I targeted as soon as the schedule came out, and I didn't think it was going to happen together, and lo and behold, this morning they've walked up together, and so we've got a treat for our opioid side of things with Dr. Mark Rosenberg, DO, MBA, FACEP, or already a little bit dyslexic this morning, Dr. Alexis LaPietra. We've actually talked to both of them several times. She's DO, FACEP as well. St. Joseph Regional Medical Center also, but more importantly, the ALTO program that has been really, both of them, leaders in addressing and going after this opioid epidemic that we're facing, but not only how do we be better stewards of our opioids, but also then what we can do to better manage patients. And they've actually had some fantastic progress over the last year and a half, 2 years or so with the program and what they've achieved. And people are being treated better for it. They're happier. There's the pain results are even more improved. So not only are we finding ways to protect folks from the risks of opioids, but we're actually finding better ways to treat them. And I can't say we're really finding it. It was already out there. It's just we're now have folks dedicated enough to find those things as well. So Mark and Alexis, thanks for joining us. Welcome back to the front line. You've both been here before, at least once, if not twice or three times. And let's start off by where we are with ALTO, with the St. Joseph Health System up in New Jersey.
Well, good morning. Happy to be here.
Good morning, everybody.
When we started ALTO 2 years ago, we kind of never thought it would boom and be such a great success. Bottom line is, in the first 6 months, we had an over 40% success rate at decreasing opioids. At the end of the first year, almost 58% improvement in decreasing the use of opioids. And at the end of 2 years, we're up to an 82% reduction in prescriptions from the emergency department and use of opioids in the emergency department.
So really what we're so excited about and why it's so wonderful to be in DC at this time is we have some great legislation on the table, including the ALTO Act and the POWER Act, which Mark helped draft and then testified in favor of in front of the Senate, I believe. What's so thrilling is we worked hard to get ALTO up and running at our shop, and we're so happy that it impacts our community, but our major goal is to really impact the entire House of Emergency Medicine and have all practitioners be able to implement. It's not terribly difficult, but you certainly need some tools. So to be able to put this into law and to help hospitals gain funding and support to put this into action is really, we're coming to the peak of what our goal is for this program. So with all of the advocates here on the Hill getting to talk with key legislators to vote in favor of these two bills, it will really advance emergency medicine and should really elevate our pain management practice. And it's really an honor to be able to be here among so many leaders.
You know, I think what's really important with ALTO and the POWER Act, both of these put emergency medicine on the front line of really being the solution to the opioid crisis. And we are leading the House of Medicine in finding solutions to opioids. I think that sets us apart, and I think that's what's so important about the visit here today.
Well, one, you mentioned these acts that are coming up, and Congress has really taken a lot of this on. And I think, you know, it's almost everybody wanting their thing out there, at least in terms of each of these politicians. There's a lot of opioid legislation out there. You know, we had a couple come in locally and talk to us about it, and, you know, they're talking about we're voting on all these dozens of laws and things that are out there. What do you see on the horizon? You've got your two here that sound like they've got some really good backing foundation. What are we seeing there in terms of potential legislation that can be beneficial versus legislation that we're seeing that may be potentially harmful or not really going to benefit us in emergency medicine?
You know, I think it's a good question, but if we look back at prior legislation that had happened at many state levels, it was the idea of putting laws or restrictions on the number of pills or the number of days that you can prescribe opioids. And this was, in my opinion, only a Band-Aid. This was not the solution to the problem. The ALTO Act and the POWER Act are a little bit different because they are looking at a solution, providing patients with exceptional pain relief without the use of opioids really benefits not only our patients, but provides the nidus, the start of a legislation that can improve, decrease the use of opioids and still give patients the options to have excellent pain relief. I think that's the big difference with this legislation versus many of the others that have been out there.
Again, I think restriction is just causing a frenzy of worry. So as physicians, we want to be empowered to use what we think is appropriate, and the more restriction we put on the doc, the more we're pushed into a corner. So opiates are important. We need to have opiates, we need to use them, but we also have to educate physicians about the appropriate use and using them more as a second line or a rescue as opposed to as a primary medication. And the POWER Act, which will allow physicians to gain access to MAT programs or peer recovery counselors. This is so important because we have a huge population of patients who are addicted to opiates now, and physicians don't know what to do when they come into the emergency department in withdrawal, in crisis. We give a little Zofran, a little Motrin, and we say good luck. But these are humans that need to be cared for, and we need to treat this as a major health crisis like it is. So this POWER Act allows physicians to understand more about buprenorphine or medication-assisted therapy from the ED, how important that is, what an exceptional public health measure it is, and really there's no other way around it. So we want legislation to go in the direction of providing care and empowering physicians, not restricting physicians and telling patients, good luck, we're sorry, our hands are tied.
That is, with the ALTO program, I got kind of put the cart before the horse, assuming that everybody has already listened to our podcast from last year, where we talked with both of you separate times about ALTO and things like that. So the ALTO is alternatives to opioids. It's not just cutting opioids, which I believe you both mentioned is a huge issue. I mean, just saying we're not going to give opioids is basically saying we're not going to allow you to use gasoline for your car and not give you another option of how it's going to drive. And in this case, we have to have options, and that's exactly what this program has done. It's not saying we're just cutting opioids. It's looking at the research, looking at the data that's available, the evidence, and what is actually the most efficacious and safest treatment modalities out there for those. I use them in my emergency department. I will completely and totally admit that I have stolen your stuff as well as the stuff from Colorado, and I'm not inventing the wheel. In fact, I'm not even taking your name off the hub. We are just putting it on our vehicle and driving it. And it's all about bringing in these actually evidence-based therapies that have always been there, but we got pushed so far from whatever complicated reasons you want to put in there to hit this easy button of the opioids, whether it's because we were told they were safe or because that they were more effective or that they weren't addictive or whatever the issue was, sold those bill of goods. And now is trying to shift back to what we do in every other area of medicine, which is go with the evidence of safety and efficacy, and so using those therapies. And so I know, Alexis, you do a lot of the trigger point or injections or dry needling or whatever you want to call it, getting in there. We actually talked about that quite a bit with back pain, talking about the Toradols and the lidocaines for renal colic and all these other modalities, just in case somebody is just listening to the podcast for the first time and they haven't really kept up with everything that's progressed. Give us a brief overview of how ALTO is set up, and we're going to circle back around and then we'll move forward once again with where we go.
Let me just start with the philosophy. And I think the philosophy of ALTO was a preventative philosophy. So the best way to prevent addiction and dependency from opioids is never to prescribe opioids. So our goal in starting ALTO was let's not prescribe opioids, but let's still give safe, effective, aggressive pain management and provide our patients with the pain relief that they deserve. And how can we do that with less opioids? I'll let Alexis talk a little bit more about the specifics, but that's why this has been so successful, is it gave emergency physicians more tools in the toolbox so they didn't have to reach in for opioids all the time to relieve pain.
So just like Mark said, our goal was to prevent. What can we use in lieu of, while still prescribing opiates when necessary, but what can we use as a first-line measure? So Sergei Matov at Maimonides in New York was pioneering this philosophy of CERTA, this channels, enzyme, receptor, targeted analgesia. Let's use a couple different medications all at once to really treat and target pain, as opposed to giving one tablet of an opiate that just masks the pain and makes you float around. And this concept he was pioneering in his shop, and we collaborated and looked at this, and we said we want to do a department-wide initiative, and he was very collegial, and we started doing some evidence reviews ourselves, and Mark and I developed a protocol for our shop that was a department-wide protocol. And it's 5 conditions. It's low back pain, headache, renal colic, radiculopathy, and extremity fracture dislocation. Each one of those has a lot of evidence, some perioperative, some orthopedic, but there is evidence out there that modalities other than opiates may work better. So we do IV lidocaine, which has been extensively researched in the anesthesia literature. We have one RCT in the ER, not a great study, but perioperative research is wonderful for IV lidocaine, a little Toradol for renal colic. And the back pain is just really a cocktail of Toradol and Tylenol, topicals, trigger point injections. We're even looking at osteopathic manipulative therapy, some stretching, things that don't take 30 minutes in the ER, but 5-10 minutes. It's a skilled procedure, and you provide better care than just giving the opioid. Nerve blocks for fracture dislocation. I know, ultrasound savvy people, this is the next level to using ultrasound as a modality, is to be able to do these targeted nerve blocks, which work exquisitely well for pain. Headache, not only do we use our traditional headache, algorithm, but what about valproic acid, which neurology talks about a lot? They use a lot inpatient and outpatient. Why can't we use that in the ED? We're very qualified. And even looking at things like Haldol for refractory migraine, or sphenopalatine ganglion blocks, atomizing a little lidocaine. So is everything vetted with RCTs and Cochrane reviews? Not necessarily, but in a crisis, we have to look at what's out there and start to judiciously use it and start studying it more, yes, but we have a great reduction in opiate use with this algorithm, and we have wonderful patient satisfaction, and our pain scores are reduced to the same amount with the alternatives as they were when we were using 50% more opiates.
I think the success of this program has changed the entire culture in the department. So instead of now reaching for opioids first, we really go to them last, and that's the whole philosophy behind this. But every single physician has bought into the fact that we want to use opioids as rescue medications only. We're not afraid to use opioids, but we're able to treat patients aggressively without the use of opioids so much a percentage of the time that we were able to decrease our opioid use by 82%, just phenomenal. But our patient satisfaction remains high. And in fact, when we talk to patients about their pain and come up with a shared approach to managing their pain, our patient satisfaction actually goes up. We've also noticed that we start seeing 3 different groups of patients, increase in those patients come into our emergency department. One is pediatric patients, where the mom is bringing them in specifically to our hospital because they don't want them to receive opioids at another hospital. We see increase in geriatric patients, particularly because their their daughter is bringing them into our emergency department instead of another emergency department because they don't want mom to have opioids and have risk of falls and that type of thing. And the third group is patients who have already been addicted or dependent on opioids or alcohol who are now coming to St. Joe's because they want to get managed without going down that dependency spiral again of taking opioids and possibly getting addicted or dependent to them.
And, Alexis, you actually had touched on this a little bit, and it's something I talk about in talks I do on opioids. And, again, I've stolen all your information to use in those talks as well. So now that you know, if I'm not arrested by the end of the day, I assume we're okay with it. The fact that we're dealing with, 3 really groups of patients. Well, I guess it's still 2. It's 2. And that's the challenge we have here in medicine. We talk about all of these restrictions, all these things that happen, but the deaths continue to go up. And when I say it's because the cat's already out of the bag, we have this group of addicted, 2 million plus folks across the country that are addicted to opioids. And so we have these 2 groups of people. We have those that we're going to have a challenge to treat because they are already addicted to opioids. And that tolerance is going up, their demand is going up, their sensitivity to pain and discomfort is going up. We have that group, and so it's more of a challenge to treat. And you actually talked about that a little bit with, talking about the opioid management strategies with the buprenorphine and other medications within the emergency department potentially. But then also where this ALTO program really shines is that second group of preventing further addiction. Not introducing them. I still hear people talking about, a 3-day course. It has zero risks of addiction, but that's simply not the case. I mean, every single pill comes with it a slightly increased risks of addiction with no zero. There is no such thing as zero in this. And actually a friend of mine is a testimony to that, where she had never had an opioid in her life, and she was given an opioid for migraines because her doctor got frustrated that she wasn't treating. And so, hey, let's just take a quick break. We'll take a week. We'll give you this, and then we'll start working on it again after the first pill. Her 7-day supply was gone within a couple of days, and she went on to a multi-year addiction, lost everything, arrested in jail 3 different times. Now has been clean for over a decade, so very much on the early stages of the opioid epidemic, and is now with her twin sister, helping other folks in addiction. And so there is no zero risk, and we can't stress that enough. There's no zero risk when it comes to treating. And you talked about pediatrics, increased risk without the complete formation of that frontal lobe, increased risk of laying down that pathway. And I think that's where my friend got into it, was other things as a young person with some alcohol and marijuana and things that helped lay down that pathway that got there. So the opioids came in and kind of filled that gap when she was in her upper 20s. And then the elderly, of course, the increased risk of other issues, the falls, the confusion, delirium. They are super high risk, so I'm happy to hear about those changes. I'd like for you guys everybody out there sitting there right now, and you guys are clearly on the front line of this addressing the opioid epidemic from an emergency medicine standpoint. Many people out there are going to be sitting there, like my particular position, where I'm attempting to change practice within the department, putting up protocols, but we still have this generational differences, very much generational differences in the way we address pain, and still on many, Dilaudid is that first button that's hit when somebody comes in with kidney stones or whatever it may be, with the argument of, this is, if you're in that much pain, you just want to feel the relief. How do we help to get these programs into our departments, especially if you're a younger physician trying to educate your senior partners and leaders within your group about these changes? How do we institute these types of programs into community emergency physicians throughout the country and get buy-in from everybody involved?
Alexis and I have gotten so many calls and get them every single day from our colleagues who want to jump on the bandwagon. This has not been anything where I have to twist somebody's arm to convince them. In our shop, we have over 60 providers, and every one of them jumped in with 2 feet right away because they wanted to have this alternative approach to managing pain rather than just going to opioids. Even here at Leadership and Advocacy Conference, part of the handouts that are given to everybody who registers is all the algorithms for the ALTO protocols. This is not proprietary. This is something we want to get out to everybody in the emergency medicine space. And part of the reason that we're actually doing that, honestly, is because since I get called every single day or an email every day because people want me to send out the protocols, we're just trying to get them out there for everyone. Also on the St. Joe's website, these protocols and algorithms are all available for somebody to click on and download, because we want to make sure that everybody who's interested in this has the ability to access these protocols. And we really want to start a national conversation, because as we develop new strategies and new protocols, that we can all share them and together manage this new opioid crisis that we're dealing with.
I would challenge the young physicians out there and the physician champions to be somewhat aggressive when they talk to some of their senior partners or some of the older docs, and they have to really impress upon them. They have to get their head out of the sand. So if you've been practicing medicine for 5 to 10 years, you have contributed in some fashion to the opiate epidemic, and that's okay. We try our best not to, but if you're not paying any attention to what you're prescribing and you're not entertaining any alternative therapy, you are absolutely hurting someone. You're hurting one of your patients. There are better therapies, there are evidence-based protocols out there, so why not adopt them? We are not picking a new medication that's never been vetted, that's never been studied. We're gathering multidisciplinary literature. So although there's not every medication has been studied in the emergency department specifically, for example, gabapentin has been studied by neurology and anesthesia for neuropathic pain. We're bringing it into the ED, not inappropriately so. So to say I won't use gabapentin because I didn't use it in training and there's not good ED RCTs means your patient is going to get something that does not work as well, and you're putting them at increased risk. So we just have to take our heads out of the sand. We have to appreciate we're not giving medications that have terrible side effects and create more mortality. We're preventing the mortality. We're preventing the morbidity. And we have to appreciate in crisis, we need to rally. So if you care about your patients and you want to do good medicine and you want to continue to explore what is up and coming in medicine and not be practicing from 2005, then this is what we're doing. Opiates are a crisis. There's good evidence out there. Take some time, go slow, but realize you have to catch up to the pack and you have to do appropriate pain management, and that means you're using alternatives.
And with the alternatives, keeping in mind that, even the dosing of Toradol, ketorolac has changed since, if you haven't used it in the last 5 to 10 years, has changed. Understanding that therapeutic ceiling, beneficial therapeutic ceiling associated with NSAIDs. So now I don't write more than 600 of ibuprofen, even though, even looking now, it looks like it may push down to 400.
Yes.
And ketorolac, if you're giving anything more than about 10 or so, 7.5 to 10, you're really not adding much in terms of pain relief. So we can actually decrease that exposure and risk for side effects and still get that beneficial pain relief. And so, there is a little bit of work out there, but your doctors, your nurse practitioners, your physician assistants, this is your job, is to learn and to learn continue to learn every single day how you can do better and safer with our patients, understanding that the opioids are not the answer. They are a tool that can be used when needed, but honestly, they are not the end goal. And there is work we're going to have to do, especially with, talking about learning about the trigger point injections, about doing nerve blocks. That's something that my group is working on right now, on educating everybody on the ultrasound guided nerve blocks. And yes, so there is a learning curve there. But we're seeing, our elderly, my average patient coming in the emergency room is like 108 years old. I mean, really literally about 85. And so we probably get 3 or 4 hip fractures a day. Easily, and they initially may get some pain relief when they come to the ER, some medication to help initially, but then that next call, as soon as we know where we're going, is to anesthesia. Right now it's anesthesia, eventually it will be us, to do the nerve block. And so then the patient gets very little, if any, further systemic pain medication. Can we target our therapies to where we're treating the source of pain and not having to treat the whole person? Giving systemic and the associated potential side effects with that. Another thing to think about, you mentioned the gabapentin for neuropathic pain. I just got a call this morning right before you guys walked up about doing a TV segment on the potential abuse of gabapentin, understanding that there is potential there as well. So, you still have to have that vigilance to monitor, especially risk stratify those. And that's, as I see this, I think the opioid epidemic really symbolizes where emergency medicine is going and taking such an important and integral role throughout the entire healthcare system, where, if you look at the statistics, the number of opioids with regard to the entire healthcare system through the emergency department is very small. But still, at the same time, we are going to be the ones that are probably impacted some of the most, with people coming in, looking for pain relief, looking for treatment, the source of acute care pain management. Can we actually establish the patient on a decent pain relief, pain management strategy before they get to that primary care physician, where many of these long-standing opioid prescriptions are going to be written? Can we get the ball rolling and get the patients on board with that? One question I want to ask you is people get into these programs. We've talked about how do you get kind of some buy-in. What's the initial pushback that you guys experienced? What was some of the initial pushback challenges that you faced when getting this program? Because clearly you had almost a stepwise buy-in as people became more comfortable going from 38-40% to 50-60%, now up to 82% of decrease in opioids. What's that initial pushback, and how did you guys overcome those speed bumps? One thing I found in medicine, if you're doing something new and different, a little speed bump can often derail the whole train.
So Mark was in charge of addressing the C-suite with a lot of these issues, as he should be as our chairman. So I fortunately did not have to go upstairs and fight for it. But what I heard from Mark, and I'll let him speak to it more, is that he didn't really have to fight at all. He said to our CEO and COO and CMO, so people are dying. We may be prescribing the thing that's killing them. We want to change that and launch a patient education, physician education, and patient safety initiative downstairs. LaPietra is going to be in charge somewhat, and we're going to do it. Are you on board? And I think the answer was?
Absolutely. We were very fortunate. We have a history of innovations at St. Joe's, so this was another one of our innovations. So our CEO says, Mark, I'm on board, just don't cost me a lot of money. And that's how it went with ALTO in developing that. But we're fortunate. Other hospitals who are attempting to start this protocol run into silo issues. Anesthesia does not want them to be using nitrous oxide, for instance. And so those issues need to, or doing ultrasound-guided nerve blocks, anesthesia and their pain department want to do that. We were very fortunate at St. Joe's that we have a good relationship with other departments, so we were able to sidestep some of those issues. I think another big issue is the pharmaceutical industry and the managers of prescription plans are not necessarily on board with decreasing the use of opioids. So some of the medications that we would want to prescribe, like Lidoderm patches, they would say we cannot prescribe because they're not part of the formulary. But at the same time, Percocet may be part of the formulary. Look, we can sidestep a lot of those issues by prescribing other medications, but we're not all in line with some of the solutions that we need to develop to decrease opioids. Either you're part of the solution or you're part of the problem, and that goes for the House of Medicine, that goes for the pharmacies and the pharmacy, the prescription administrators for different plans, that goes for the C-suite as well. So as we start changing things at St. Joe's and other hospitals are picking up some of these protocols, we are having a national conversation of let's change how we're managing opioids, let's change how the House of Medicine is doing it, and let's streamline everything so that we have an ease of best practice. Let's not rely on opioids when we don't have to. Be part of the solution, not the problem.
When I speak about implementation, depending on where docs practice, there are certain questions that come up. So we are in a charity care, Catholic-run, not-for-profit hospital, where we might not have, we have demanding patients, but we might not have that upper crust of very demanding patients who know exactly what they want. I mean, we are in a really a wonderful community where the doc is in charge a little bit, and our patients are very grateful, and there's really a discussion that we have when we treat them. But I hear a lot of physicians say, listen, I have these patients come in, they're insured, you know, they come in, they know what they want. We're in somewhat of a concierge service in some of these plans in some of the parts of the country. And when I tell them they can't have Percocet or Dilaudid, I get a complaint against me, and now my chairman or my CMO is breathing down my neck about why did you not just give her or him the 15 tabs of Norco? And what I'll say to that is, when you implement, it has to be a department-wide initiative. It's hard for one doc floating around in the ED to start this transition, because when issues arise, they need to have departmental support to be able to be empowered to treat properly. So starting this program with the chairman's support and hospital administrative support is very important. When you get issues like this, patient satisfaction issues, there needs to be an understanding that we're trying to practice good medicine, evidence-based medicine, and I'm sorry, but we don't feel there was an indication to prescribe this at this time, but you can follow up with primary care or pain management. So we don't want our docs to dig themselves into holes where they feel like they can't provide what the good evidence shows that they're getting in trouble. So we don't want docs to feel like they're going to get in trouble from their administration. So department-wide support is very important, and understanding that there's evidence behind this. You can get this at follow-up, but we're not going to do this from the ER.
It's a hard situation, a place to go at it Lone Ranger. I mean, you're definitely going to have complete buy-in, and there is going to be significant challenges out there, because I know some administrations, some hospital systems are complete a-holes, and they're not going to, this isn't going to work for them. I mean, they're going to make this incredibly difficult. The drug industry clearly does not want what's best for the patients in these cases, or my lidocaine would be $3 for as many as I want to order, as opposed to the current Medicare payment, which is $3 for as many opioids as I want to write. We are fighting a system that really does not have right now our patients' best interests in mind, and yet a lot of the focus is going on to the physicians for this crisis, when honestly, now the wave of trying to fight against this crisis is really working against us. With, you guys are in a perfect situation. You guys have a great hospital system that has bought in all the way. We have other systems that aren't going to be, as open-minded. There's going to be systems that are going to be downright resistant to this sort of thing. But, I see an issue coming up that if you don't change, it's going to be the equivalent of your ipecac or bloodletting. Are you going to be the last ones doing bad medicine? I mean, what do you guys see in the future coming up in terms of possible repercussions or issues if you don't start to address this system and policies within your ER?
St. Joseph's is not a big workers' comp program. We just don't have that there. We've never started it. But over the past 2 months, a large number of hospitals and industries in our community are now approaching St. Joe's because they want to send all their injured workers to St. Joe's because they want them to have ALTO protocols rather than opioids. I think as we look at the future, if you're not going to provide state-of-the-art pain management without relying heavily on opioids, you're going to lose out on a lot of the patients that we like to take care of, particularly those worker comp cases, because they're good payers to the hospital, and we can refer them into other programs as well, so we have a good transition to care plan. But you're not going to see those patients if you don't provide ALTO protocols or opioid avoidance protocols to manage those patients.
I think when we look especially at the geriatric population and you start gathering the evidence about hip fracture, which has a very high mortality if not managed properly, some of the benchmarks are going to be, what are you doing for these geriatric patients? And one issue is oligoanalgesia with the hip fracture, but also delirium. So there's a study that looked at if a patient has under treatment of pain, they're 9 times more likely to become delirious than if you do give them the appropriate amount of morphine. So under-treating with morphine is just as big of a problem as over-treatment. But you can get rid of all that morphine by doing a block. So we don't have to, so there's this balancing, the scales that get tipped. You don't want to give too much pain medication to some patients. You don't want to give too little to others. So we're looking at pain scores that we have to deal with. We're looking at patient satisfaction that we have to deal with, and we're looking at length of stay. A lot of this can be wiped off the table by using alternatives that are non-sedating, not constipating. Patients are up, patients are moving, patients are not delirious. So length of stay is a huge driver in hospitals, and I think that using ALTO protocols changes the dynamic of length of stay because they're not an opioid and they're not as sedating and they don't cause a lot of these other fall risks and delirium, et cetera. So looking at the mortality and morbidity associated with opioids, when we wipe a lot of them off the table, I think the healthcare systems are going to see improvements and the benchmarks are going to change for the quality of care they're providing.
And Mark, you mentioned that your CEO said, just don't cost me too much money. It sounds like that what went from, don't cost me too much money, transitioned to making the hospital system not only looking like a hero across the country. I mean, I'm not sure how often St. Joseph Health Systems in New Jersey was on the national conversation before, but it's definitely been for the last 2 years with your programs. Now sounds like you're potentially making them some piles of cash with bringing in those different groups that are happy with the services and things that you guys are offering that are a little different. Were you guys surprised with the results that you had? I mean, I know you expected change, but were you surprised at how successful the program has been?
I not only was I surprised when we started it and we had complete buy-in from all our physicians, not only was I surprised when my CEO says, I like what you're doing and keep doing it, not only was I surprised when industry in the area decided to start sending their patients, their injured patients, to St. Joe's rather than elsewhere. But I'm totally surprised at the national conversation now. To think that there is a bill in Congress, two bills that are called ALTO, Alternative to Opioid Act, and they even mentioned St. Joseph's healthcare system as part of the national conversation. This is something I could never, ever have imagined. And it gives me a little bit of job security as well.
Mm-hmm.
So
Yeah,
everything about this has been a great surprise. And the other part that actually energizes me even more is here we are at Leadership and Advocacy, and my colleagues are walking up to me and walking up to Alexis and saying thanks. This has really changed my practice for the better. So there has been a lot of good surprises here, Ryan, and absolutely has been a good journey.
Who came up with the name ALTO?
Dr. Mariana Carunos, our chief in our emergency department.
Are we sure he hasn't
She
didn't copyright it?
Well, the hospital did.
What?
It is registered service mark of St. Joseph's Regional Medical Center, ALTO. But we were out to an executive lunch trying to work through ALTO before we even launched it. And what is it going to look like? And what are the nurses going to do? What is the doc going to do? And we kept calling it Alternatives to Opioids. And it takes 10 minutes to say, and everybody keeps saying it 50 times. And we all just looked at each other. Maybe we had a little wine. And Dr. Mariana Caruno said, Alternatives to Opioids. ALTO? And oh my gosh, the record stopped and we said, yes. We realized it means high in Spanish, but we're high on the idea that we're doing better patient care, and she gets credit for the name. We don't often give her credit, but she's a total gangster and is a huge champion. She's geriatric trained, but she did come up with the name, so we have to give her that credit. Mark and I may be the pioneers, but she holds the name.
So Alexis, tell me how your thoughts were on the response of the success of the program.
Flabbergasted, is that a good word?
Yeah, it's
flabbergasted.
A good one. It's not used near enough.
Okay, well, here we go.
Again,
I was flabbergasted. Mark said to me when we talked about my fellowship training, he said, I think it's going to really change your career to get this pain management fellowship training under your belt. It will, understatement of the lifetime. To have that pain management training when no one else really does in emergency medicine, I think it will change your career and change your career trajectory. And really, I'm amazed. I am just honored to be part of it, and I think there's a bit of timing. I had this training at a time when there was a need, but I feel blessed to be surrounded by people who supported me and who believed in this project. And we hope it's affecting change. And I thought, if we have a little bit of a decrease, it's a win. Any decrease is a win. But more importantly than the opiate decrease is that we've maintained quality pain management. Mm-hmm. So I don't care how much we've decreased the opiates as much as I care that patients are getting out of the ER with less pain using something not as potentially dangerous. So that's where my heart gets warm, is to see the trigger point injection, the silly little trigger point injection, and the patient stands up and gives me a hug and says, I'm ready to go back home, thank you so much. And all I did was put a 25 gauge needle and 2 cc's of lidocaine in this terrible spasm. And a couple years ago, I would have never known to look for that or to palpate or do that procedure. So these little tips and tricks are somewhat easy, and it's so great to have them in our toolkit. So just amazed at how well the program has done, and very excited that hopefully in 10 years when we're talking again, we've seen the transition out of opiate addiction. We've seen improved quality pain management in the ED. We've seen that we pioneered this movement, and we're on to the next thing.
The bad thing is I actually thought of you a couple of weeks ago when I torqued my back, and I could feel it in my back, and I was like, oh, I need Alexis because I've got a trigger point, and I could feel it, and I knew it, and I remembered our conversation that we had, and if I had an owl head and could look at my own back and
There you go.
jam a 25 gauge needle back there.
I've never been to Kentucky.
and you would love it this time of year. It is incredible. I wouldn't have been in great shape to take you around and show you all the distilleries and the horse racing and
lovely.
the green. And I mean, it's it's when we come to these conferences, there's always this. Everybody comes up. They come to you guys talking about proper pain management. For me, it's what bourbons are good.
Oh, that's fun.
And I don't know that that's a healthy thing, but with being in Kentucky, I've got 5 distilleries within about a 30-minute drive, and So yeah, you're welcome anytime.
Good.
So I'll try to. You tell me what's good for your schedule. I'll torque my back again. I'll go out and lift some logs and split some wood or something and tear it up again, and you guys can come down and have a reason to make it a work trip. To come down there for a trigger and point injection, then we may happen to then
bourbon tasting.
And bourbon
there
tasting.
We go.
There you go. All right. Any final thoughts from you guys as we wrap up today? Just anything that hits your mind with this? Some take-home messages for those listening to us right now.
If you have any desire to implement change, do it. Pick something. You don't have to do the whole ALTO protocol all at once, but just try trigger points, or start using more lidocaine patches, or start looking at biceps tendonitis injections, low paracervical spinal blocks. There is a huge list of alternatives. You don't have to necessarily start all the way at the top. If at a departmental-wide protocol is best, but hey, if you're the Lone Ranger, as you said, and you're in the ED and want to just do something to improve the care you are giving to your patients, pick one modality or one medication, do some research. You can find my email on the internet because everybody else does. Email me. There's good YouTube videos out there about alternatives. Larry Mellick does a good trigger point injection video. So just try to pick one. If you just do one little thing, before you know it, you're going to have a huge impact on your patient population. So we don't want this to be this huge package that if you don't have CEO clearance, you can't do. You can make small changes. It's going to always be for the better, and that will improve the care you give to your patients every day, and that is a huge win.
I think it's real simple. If you're not part of the solution, you're part of the problem. The solution is ALTO and protocols like that. So reach out. We'll help you get started. This is something that is part of the solution for the country, and ACEP is leading the way here, and I couldn't be more proud.
And how can folks get in touch with you guys if folks have questions? How can folks get in touch with you?
Email is probably the best way. You can get me at mrosenberg@acep.org.
And you can get me at LaPietra, LAPIETRA, at sjhmc.org, St. Joseph's Hospital Medical Center.org.
And you're on the social web as well?
Oh, Lord, reluctantly.
Yeah.
I don't know what I'm doing. I need a tutorial on how to exist in the Twitter sphere, God help me, whatever it's called. So you can try, but you should
What's your
probably
handle
email
on the Twitter?
Dr. Alexis La. But that doesn't mean I am an old soul. God help me.
At Dr. M. Rosen.
There you go.
I'm there.
And as for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, at everydaymed on Twitter. And you guys may look, I'll have to tag it here in a minute, but I've already put up a photograph of you guys doing this interview on the Twitter. So good chance you may never see it, but everybody else will. And until wonderful discussion, I hope to continue to have you guys back as a rolling progress of how the opioid epidemic is evolving, the management from the emergency medicine standpoint, and truly leaders within emergency medicine for this, and something we're going to be talking about on Capitol Hill here within the next 24 hours. A lot of these things that you guys are pushing from St. Joseph Health System in New Jersey. So thanks so much for joining me, and hopefully we'll be talking to you guys pretty soon. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.